Good morning, everyone. I think Dr. Sujit is a dear friend. He's very humble enough to call me a teacher, but probably we've been together at a time when I had just joined Nizam's Institute as assistant professor, and he had joined his journey as a fellow there. So I think together we learned a lot of things, and yeah, we moved ahead in life, and we are here where we are. So I think it's not that I am his teacher. There's been a lot of learning from me, from him also. So I think he's already briefed about the topic today and its importance. I completely agree that cancers in India are on a rise. Is my slide moving?
Yes,
Yes,
madam.
madam.
Yeah, sure. Cancers in India are on a rise, and it is interesting to know that head and neck cancer is 7th most common cancer in the world, but in India, it is the most common cancer in males. And 30% of all cancers in India are head and neck cancers. And particularly when I was looking for the Aurangabad and the related area, about 30 out of 1 lakh would be the incidence in Aurangabad area. So we are actually looking at really high numbers, and these numbers are probably going to increase. If we look at the causative factors, tobacco is a very important reason why head and neck cancers are common. They are common because many more youngsters, we find them smoking. So both smoking tobacco as well as smokeless tobacco, along with other reasons like alcohol, the increased radiation exposure around us, nutritional deficiencies, betel quid chewing, and I think the whole stressful lifestyle, all of these contribute to head and neck cancers. And so I think that the first challenge for us that I want to share with you all today is the challenge for the entire society of being able to face cancers, particularly the head and neck cancers. And hence, as anesthesiologists, I feel that it is our duty to create awareness amongst the society. I know Aurangabad.She branch under the able leadership has been doing a lot of public reach out activities, and maybe you should consider head and neck cancer awareness as one of them, as a tribute of giving back to the society. Now, talking about challenges in head and neck cancers, I feel airway is and compromises the biggest challenge. And how I would like to put it is that if you anticipate trouble and be prepared, you can tame this tiger. But if you fail to anticipate, you might just get caught. So this is going to be the theme for today. Let me begin with asking what people think. Do you think that all head and neck cancer patients have a difficult airway? I know there are many senior people, and there are many people who are practicing head and neck. Head and neck is what they told me now. So I'm sure you'll agree that not all head and neck cancer patients have a difficult airway. Roughly, the incidence is about a quarter. But what is more important and challenging is to identify which one is going to be difficult. So if we look at our traditional teaching, we've been taught to assess the airway by performing a standard set of tests, like checking for mouth opening, how many fingers, looking for Malampatti scoring, checking the neck movement, the ability to bring the lower jaw forward, and maybe a little more complicated things like thyromental or sternomental distance. But unfortunately, literature shows that these standard airway assessment tests have very low sensitivity, which means that they will fail to predict a difficult airway in many patients. I will not really go into the numbers and percentages. I just wanted to say that this talk, I have left out many academic areas just to have it more of a discussion and to be able to put forward the concepts. But I'll be happy to dig deeper into some of the academic areas in case any one of you is interested in the Q&A part. So what should be our goal whenever we are trying to assess a head and neck patient? So I think the most important goal to avoid landing into trouble is to detect obstructive pathologies. Now, this is because if there is anyone who has significant obstruction, whether it is overt or not overt, if these patients land into apnea, it is going to be catastrophic. So how do we go about it? I think some important points that you should never miss whenever you are assessing these patients is asking for hoarseness. Now, hoarseness, maybe you already know that the patient has glottic tumor, but hoarseness could still point towards edema in that area, maybe infection, inflammation in that area, which is going to further narrow the glottic opening. It also points to nerve involvement whenever you are dealing with thyroid malignancies. This has implications, legal implications, that you need to document the recurrent laryngeal nerve palsy if it is present before surgery, and we'll talk about it a little later. The other important point is dyspnea. Now, dyspnea information can be very subtle. You need to ask if there has been a gradual reduction in effort tolerance, meaning if they were able to walk a particular distance and now they are unable to or start feeling dyspneic at the same distance. These findings can be very subtle initially and could point towards deviation of the trachea, narrowing of the airway at any level, or it could also be pointing towards cardiopulmonary causes. And why cardiopulmonary causes are important in head and neck cancers, also I'll be talking about it a minute later. But more than these two, probably more important is to identify orthopnea, which means that the patient requires just a specific position, probably a little propped up position, cannot really lie down comfortably or is able to lie down only on one side. And if that is the case, then which side the patient is comfortable in is very important to ask. And this usually is seen in patients where there are large pharyngeal or neck masses or even anterior mediastinal tumors, and I'm not going to cover anterior mediastinal masses today. But the most life-threatening is a stridor, where there is overt sound, signifies significant airway narrowing, and probably these patients would require tracheostomy before they are and stabilization before they are taken up for surgery. Now, let us start with focused history and examination. I'm not really going to delve into what else and everything comprehensively, but talk about really what is important, or maybe I thought is important to be covered here. There could also be other important points, and please feel free to discuss them in the Q&A because I may not be really able to cover too many things looking at the time assigned. So, as I said, that there is going to be in most patients history of either smoking, alcohol or tobacco. This history is important to take because we need to allow them to stop smoking, stop alcohol, stop tobacco before they are taken up for surgery. This can be a little challenging when you are doing it in private scenarios, but trust me, this affects the overall outcome of the patient. And it's more important that your surgeon gets convinced that these things are important. Coexisting diseases. We've seen a very high incidence of hypertension in these patients, and they are de novo hypertension. Like maybe the patient wouldn't know that the blood pressure is high, but when they come to us in PSC clinic, we find that their blood pressures are high. One important reason why this can occur is because of the high sympathetic innervation of the tongue, oral, buccal mucosa and maybe because of the pain that they have. So this can be related to that, and we need to optimize the blood pressure before we take them up for surgery, because some of these patients, after the resection is done, their pressures will stay very low. So that balance needs to be maintained. Again, smoking is associated with coronary artery disease, and we see young smokers having coronary artery disease at a very young level. So if you're thinking that, oh, someone is just say 40 years old and may not have coronary artery disease, if the person is a smoker, there is a high incidence that there could be a possibility, and it may be good to ask for a treadmill test in patients whom you think that there is a possibility. Also, long chronic smokers can have COPD, and these are some of the important things that you should take history related to. Most of these patients for a couple of weeks would be taking either diclofenac or some form of NSAID, and we have seen that their creatinines would increase borderline. So again, looking at the serum creatinine value, asking them to stop the NSAIDs at least 4 to 5 days before surgery will actually help reduce the acute kidney injury that can occur perioperatively. Previous radiotherapy and surgery is a possibility in this group of patients, and I'll just tell you how it can affect. So radiation these days has been more focused to the area where it is to be delivered, and this kind of woody stiff neck that I've shown on the right side is relatively less common, what we see because of the linear accelerators that are used for radiation. But we still get to see once in a while patients who have these woody stiff neck. Do not look difficult when we look at them, but when you feel and when you palpate them, you will feel they're stiff. So remember that there is going to be edema inside, there is going to be fibrosis and distortion inside, and there'll be very little space for displacement. So this is one group of patients where you may think that the airway looks relatively easy, but it could turn out difficult. Your view is going to be restricted. So you need to remember this part. So this is an example. I've just put in a video. I hope the video is playing. That the larynx is just stuck there. You can see there is so much of edema. The larynx inlet is narrowed and it isn't really moving. It doesn't get displaced when you lift by laryngoscopy. So you have to be very careful in these group of patients. Previous surgery can significantly distort the airway. There can be bone loss, there can be muscle loss, there can be contractures. And even if it looks relatively normal, remember that because the muscle configuration has changed, there is going to be loss of airway tone under anesthesia, meaning it will be more difficult to ventilate this patient when the patient sleeps. Very important question to ask for your patient would be, does he snore during sleep, and what is the comfortable position again for these type of patients where they have undergone a prior surgery? That will give you an idea, one, whether there is loss of significant airway tone, and second, what should be the comfortable resuscitation position in case you lose the airway tone under anesthesia. Now, airway examination again is going to be very focused based on the tumor location, whether it is the lip, the cheek, the tongue. What I am really worried about are the tumors that we can't see overtly, meaning if there is a tumor at the posterior 1/3 of the tongue, I am more scared about that tumor because it is not visible to me. It is encroaching on my airway and it can cause difficulty in ventilation, and of course it will cause difficulty in putting my laryngoscope. If it is friable, it can bleed on touch. So these are the different points that need to be kept in mind whenever we are handling these airways. Also, if the tumor is not very big, then which side the tumor is, whether it is right side or left side, is very important because we use the laryngoscope which is right sided, and probably it is okay to have a tumor slightly on the left side if it's not encroaching on the airway much, but a right-sided tumor would warrant some different airway management. Some other basics in airway examination are, because most of these patients would require nasal intubation, checking for nasal patency. So traditionally described at looking at the fogging, or even you can just put up the nares to check which side looks more roomy. You can ask the patient to breathe or blow through each nostril and identify which one is going to be bigger. What is not really seen but could be inside is the bony spur, and for that you need to pick up the CT scan and check the nasal cavity. So if you are going to do a nasal intubation, probably it is a good habit to run through the CT scan. As you can see in this image, there is a bony spur, that a large bony spur, in fact, that completely crosses the cavity, making it practically impossible for the nasal tube to be pushed in from that side without causing trauma. And same is reflected on this side on the CT scan. Also, this was an interesting case where this patient, after undergoing palatal tumor resection, had a mesh that was placed in that area, and that mesh had extruded. So though the surgeon wanted us to have a nasal tube, we had to put in an oral tube first, allow him to remove the mesh, and then change over to a nasal tube so that he could reconstruct it later. Regarding investigations for large thyroid tumors, the standard teaching that we've had is to ask for X-ray neck, AP, and lateral, which anyways is done in our hospital for a different reason. But what I would personally prefer to see is a CT scan. CT scan is the gold standard for evaluation in head and neck cancers, and most of the times it is the surgeons themselves who would ask for a CT scan. So if you look at the CT scan image here, you can see how the trachea is gradually narrowing and it has become significantly narrowed now. It is important that you yourself should learn to read the CT scan so that you are able to understand what is the level of the obstruction. So you need to start counting the cervical ribs, cervical vertebrae to identify what is the level, or you can look at the clavicles. As you screen lower, you will find the two medial head of the clavicles, which are usually at the sternoclavicular joint, and that will help you identify whether this obstruction is above the thoracic cavity or is it into the thoracic cavity. And the implications for obstruction into the thoracic cavity are significant. MRI is also done in certain cases, particularly where they want to do more of a soft tissue evaluation, like the base of tongue, parapharyngeal masses, or sometimes even the PNS tumors with extension. As I said, please learn to interpret scans by yourself. Don't just read the reports. The reports are written by a radiologist who probably has no clue as to what is important for you. And even surgeons sometimes may look more at their perspective in the scan than being able to share critical information about your perspective or the airway perspective. Now, just for an example, this is a gentleman who looks fairly with a good mouth opening. He has a good neck extension, and you would think that he has a decently good airway. But only if you pull out the CT scan, you would realize that he has a large parapharyngeal mass which is encroaching onto the airway to a point that it is becoming smaller. And particularly these patients will give you history that keeping the tumor side down makes them more comfortable. So always ask for this history, because that will help you understand if the tumor is going to come and encroach into the space if you are going to start supine for this patient. Now, there is a lot of hype about ultrasound, and so there is about airway assessment with ultrasound. And there are a lot of parameters that are defined, like tongue size and volume, the pre-epiglottic space, whether the hyoid is visualized intraorally or no, or calculating the hyomental distance. But for today's session, I think I don't want to dig deeper into these things. And though it is a possibility with certain case reports or with certain parameters that has been described, I think we are still largely evolving into our understanding how airway ultrasound can be used or implemented for the head and neck cancer cases. There are limited indications, and I'll be sharing. So this is one of them. I think it is very useful to help mark the front of neck axis. Now, you wouldn't understand the reason till I give you an example. But what I wanted to show you in this slide is how to identify the front of neck axis. And if you put the probe, a linear probe vertically, this is roughly what you would get to see. These are black shadows which are showing the cricoid cartilage here and the tracheal rings here. And of course, the cricothyroid membrane is going to be above, which is not seen in this. But this is shown to be able to mark rings for emergency tracheostomy, because I believe that whenever we are doing head and neck cancer cases, we are usually with an ENT surgeon or a surgical oncologist who is well versed in performing emergency tracheostomy, so that we don't have to really think about cricothyroid puncture for these cases. So this was one of the patients that I wanted to share. As you can see that the patient has a huge mass, an exophytic mass, but the entire skin is very tense and bulging. And of course, when I pulled out to see the CT scan, focus on the CT scan and you will see how the airway starts becoming narrower. This is the epiglottis that is seen. Epiglottis is also completely constricted and the whole laryngeal inlet barely becomes a slit when he is awake and sitting propped up position. But what is good to know that the trachea below that level looks decent. There is a lot of tumor around this trachea. So the surgeon found it very challenging to decide whether to do tracheostomy and how to do the tracheostomy. But we knew that if we did not do anything for this patient, the patient would die. So we decided to go ahead with tracheostomy. So these are some of the images. Contrary to how you would want to imagine the trachea would lie, look at the area where the trachea is. It's extremely lateral, and that's because of the tumor, the way it has expanded. And even in the scan, if you remember, we realized that it's extremely deviated. So first thing is your scan is going to help. Second thing is, if you use we use the ultrasound linear transducer to scan the entire area to identify roughly where the trachea is running vertically. We could identify a space roughly here, which had relatively less thickness from the skin, because as you know that the depth of the tracheostomy tube is limited. If you select a place which is very deeper, you may have to really push in the tube too much and it might come out of this, losing the airway, which we did not want. Even while they were doing tracheostomy, like in this picture, if you see my linear transducer, the hockey stick probe that we call it, I have covered a sterile glove over it, and we had put it inside to identify the center of the tracheal ring so that they could open it. So these are certain situations where I feel that ultrasound is extremely useful, and you in a habit of identifying these structures really helps you give the care that is required for that patient at that point of time. Other investigations, I think pre-op vocal cord palsy, I already mentioned that it has to be documented in patients undergoing thyroid surgeries. Again, evaluation in the OT. Maybe the pre-operative indirect laryngoscopy has been done by the surgeons, say, a couple of days back. But if in rapidly growing tumors, we've seen that sometimes the symptoms may increase. And if you have a patient whose symptoms have increased recently, like in this patient where the tumor recorded officially in the indirect laryngoscopy was something like this, but when we actually performed again an indirect laryngoscopy in the OT before we started, this is what we could see. So you can see the epiglottis. You can't see the cords at all. The whole tumor is actually covering the cords. So initially, what could have been a possible fiber optic intubation probably has now turned into a upfront tracheostomy for this patient. So the plans can change. So make sure that these tests are done recently and there is no gross increase in the symptoms in these patients. Some patients might still require a little longer visualization. It's not possible only with indirect laryngoscopy, and that's when you need to pull out your fiber optic bronchoscope, get the patient in the OT and assess the airway. So this needs to be done if the patient has an infraglottic growth, which could be laryngeal, or it could also be thyroid, where there is intratracheal extension. Also, sometimes because, say, post-radiation or because of other reasons, there can be poor view from the indirect laryngoscopy. As you can see here, either the cords are like this or it is that there is significant narrowing and you cannot see anything beneath. You need to do a fiber optic bronchoscopic assessment. I'm sorry, I realized this video was not running, but what I wanted to share with this case that we had is that this was a very big tumor just lying periglottic area. It was practically obscuring. I don't know if you are able to see. This is the tumor here. This is the epiglottis and one arytenoid. And we actually got this patient for optic bronchoscopic evaluation, and what we realized, which I cannot demonstrate because the video somehow is not running, is that the tumor actually collapsed completely and we could see the complete glottic opening. It was extremely surprising for me. This was the first time I had seen something like this, and what I realized is that there is a cystic cavity, there is a fluid filled cavity inside the tumor, and that had actually helped collapse the tumor such that the airway practically looked normal. But every time the patient strained, it bulged up. So we had decided for this patient to go ahead with fiber optic intubation when anesthetizing. But what I want to put through here is that the knowledge that if there is a cystic tumor, then it can be compressible and it can provide hope in certain situations. Again, sometimes performing flexible fiber optic bronchoscopy may be more harmful to the patient. Like in this case scenario, where there is critical narrowing of the trachea, there is infiltration of the thyroid into the trachea, and there is so much of narrowing that if you really go very close, then a patient can land in an obstructive clinical scenario where it might also be very difficult to do a tracheostomy depending on the level of the obstruction, and you may land into problems. So in such clinical situations, you can again go back and take the help of your radiologist to ask them for a virtual bronchoscopy. And how does virtual bronchoscopy really help? It creates a 3D picture. They will give you the dimensions. I'm not sure, no, maybe some other case I have that. They'll give you the dimensions that you have for airway plan. And they also tell you the depth at which this obstruction is, like after how many tracheal rings. And it will also tell you how many tracheal rings you may have to resect. Now, quickly moving on to what airway management plan you may have to plan based on the case. Now, it's the difficult airway guidelines allow us to identify the difficulty, and which I feel is very useful in these type of cases also. Like we need to identify whether this case, as you can see, this lady is going to be a difficult mask ventilation. Maybe I have to have a bigger mask, or try and have something that can seal the tumor, provided it does not bleed too much on touch. Certain cases like this are going to be difficult laryngoscopy, so we know that we do not have to proceed this way at all. For all periglottic tumors, that they are going to be difficult supraglottic airway ventilation. So the supraglottic airway pathway as an alternative, as a backup plan A, B, and C will not hold good in this clinical scenario. And in a patient with large thyroid, the difficult there is going to be a difficulty in front of neck access. And of course, I don't want to miss the difficult extubation patients where we need to plan elective tracheostomy. So I think this is all there in the ANSCA airway assessment guidelines, how to identify difficult mask ventilation, difficult supraglottic airway placement, difficult laryngoscopy, and difficult surgical airway. I'm just going to go to more practical points. So if we look at the difficult airway algorithm, I want to emphasize that certain basic facts apply. And the most important fact is regarding oxygenation. Oxygenation is most important. It is more important than intubation. Use pre-oxygenation always. I know in private practice, sometimes we lose the habit of pre-oxygenating, maybe because of time constraints or other things, but always pre-oxygenate whenever you are anticipating difficult airway. Try and use apneic oxygenation techniques, and nasal prongs is something that's quite easily available for us. The things that do not apply are actually the standard airway algorithm. And for each case, you may have to sit and discuss with the surgeon what is going to be your plan A, what is going to be your plan B, what is going to be your plan C, and make sure that provisions for all the plans are available in the OT at that point of time. Now, how do we really go about deciding this? I think first, coming back to the first question that I said, that is there an obstructive pathology? And if there is an obstructive pathology, you should plan for some form of awake intubation. Fiber optic, if available, is probably the best way. For even borderline cases, probably it is safer. And for others, I think, I'm sure you must be using either fiber optic or doing a retrograde intubation, or getting an upfront tracheostomy done if it's possible. If you're planning, if you think that airway could be relatively safer, you would plan to give anesthesia. The inhalational anesthesia with spontaneous ventilation is actually, in my clinical practice, only reserved for children who come with a difficult airway, because we can't do a typical awake fiber optic intubation in them. So we try to take them under inhalational anesthesia and try to assess how the airway is, and then decide whether a VL along with a bougie stillet is okay, or we would have to go ahead and do a fiber optic intubation under inhalational. And of course, the other technique is doing intravenous anesthesia, of which I think two important things that you need to find out are, I like to do a check laryngoscopy for all my difficult airway cases, which means after I give 2 milligrams per kg dose of propofol, I quickly, a gentle scopy, I just lift up to see what I can see and how bad it is. If I think that it's doable and able to ventilate, I think we can go ahead and paralyze. And this is typically for the borderline cases that I'm talking of. And if you're not happy at your laryngoscopic view, it is best to back off at that point of time. Some simple tips that I have, that whenever there are tumors around the airway, it's nice to use this silicone round mask, because this mask can change the shape. So if it's an upper or say maxillary tumor, or vital in this case, a lower jaw tumor, you can actually, and they are available in adult sizes also, so you can actually change their shape in such a way that you'll still be able to intubate. You should always train the assistants in your OT to help you ventilate in this way. You may be using oral airway, nasal airway, but there are still some patients who do require two-man or two-person ventilation. And the person who is assisting you should lift the mandibles up while you secure the seal with the mask. I also like to use the straight blades. I don't know how many of you still use it. There are adult straight blades available, and they're very useful in patients who just have trismus but may not have much difficulty beneath the level or around the cords, and you can easily give them intravenous anesthesia and use the straight blade. As you can see in this case, you can get a very good view of the glottis and intubate. Sometimes the space may be less. You can just push in a bougie first and then put in a tube, or either ways. Now, I want to use this forum to emphasize the importance of video laryngoscopes. I'm sure there are many of you who have it, and for those who don't, I think it has to start entering your practice. There has to be some form of video laryngoscope. This is something that I found. I am not advertising for anything, but as simple as this, which can be connected to a mobile phone, can really improve the view and save the day. This is a tip that I wanted to give you, that most of the times when we put a flexometallic tube nasally and we are trying to visualize the larynx, the tube is going to stay posterior. So in this video, if you see, it is hinging the arytenoids. So what we do is we inflate the cuff. So when we inflate the cuff in that position, the tube rises up a little, we redirect. See, here again it is hinging, so which means we need to inflate it more, and then it easily reaches the glottic opening, and then as it is entering the glottis, we try and deflate the endotracheal tube, so that you do not have to use one Magill's to handle the tube and push it in. And also, if the mouth opening is relatively less, then again putting in the Magill's and trying to handle it can be difficult. So this is a very useful tip that I wanted to share. This was an interesting case that we had. There was significant tracheal narrowing because of the tumor that you can see in this scan. We had got a virtual bronchoscopy done to see, and we could actually mark it as only 2.8 mm of internal diameter, which means I need to use a tube whose outer diameter probably would be 2.8 millimeters and has to be long enough to be able to come out of the mouth for me to ventilate, but which was difficult. And what we chose to do is to just sedate her a little bit and get an upfront tracheostomy, but not a tracheostomy, but to open the trachea just below the level of the stenosis, and we put in the flexometallic tube below it. So when the case came to me for a pre-anesthesia clinic, I think my thought process was just limited to this till I discussed it with my surgeon, and together we thought that if this length of trachea is good, then we should try and explore this option, and it worked out well for us. I'm going to run fast through these slides because our time is running. I want to say airway fire is a reality. I've had this experience a couple of years back. And so please, if you are doing any laser surgeries without using any laser protection on your tubes, then please be careful. You can land in trouble. We are using the laser flex tubes that are available, the Malignancy laser flex tubes. It has two bulbs, one of which is filled with methylene blue and saline, and it helps us identify if there is any cuff puncture. There always has to be a jet ventilator with you whenever you are handling these high-risk airway cases. And this is one type of jet ventilator that actually helps you adjust the pressure, the maximum pressure that can be delivered. So we can use it over a wide range of cases. Someone who's hefty, we can keep the pressures high, which is like 2 bars. And say if we are dealing with children, we can keep it a little lower, maybe around 1 bar. High flow devices, I think COVID has really helped us in having more and more of these devices, which can also be used in the operation theater. But I'm really going to skip the discussion. I want you all to have all the difficult airway equipment that you have kept in one place. It can be one box or it can be one trolley, but everything needs to be together so that in an emergency, everyone knows where it is and to get it. I also want to say that it really doesn't matter whether you have expensive gadgets or resources, as long as you know how to use your things well, I think, and you know where to stop, what cannot be done in your setup, I think you'll do well. A couple of things about intra-operative period. Sometimes the large thyroids which extend into the mediastinum can be major surgeries, significant hemorrhage, vascular reconstructions may be required. I always wanted to show this picture because the flexometallic tube, which is typically called as the kinkless tube, can kink under the drapes. So make sure that how you, or maybe it is the newer generation of flexometallic tube. The older ones, I think, were more sturdier. But you can see here that the wire, the connector and the flexometallic wire junction has kinked. Sometimes there can be airway injuries. Like you can see here, the whole of my endotracheal cuff is seen because the trachea has got opened such a big time, and they had to actually reinforce this part by creating a patch. There can be transections of the endotracheal tube, and sometimes even a small nick near the pilot balloon area is sufficient to cause leak. So always when you put in the nasal flexometallic tube, because this is typically this complication can happen in maxillectomies where they use the electric saw, try and make sure that the pilot tube is rotated on the other side so that this problem does not occur. This is just showing that if you have an airway exchanger, you can actually, without changing anything major in the surgical position or the surgical field, just by wearing sterile gloves, you can actually get your tube changed. I also want to talk quickly about extubation. Extubation needs a plan. You need to know whether you can extubate this patient either on the table or sometimes delayed extubation, which can prevent a lot of tracheostomies. Now, tracheostomies, yes, they are safe, but they can come with a lot of morbidity for the patient, and you have to be extremely careful when you take this decision. So how do we do that? In our hospital, if the flap is extremely bulky, if bilateral neck dissections have been done, if there are large thyroids where we expect that the cartilages could be soft, if there is resection involving beyond midline, if a gross floor of mouth is removed or base of tongue is reconstructed, as in this image with a PMMC flap, mandible is extended beyond midline, these are some of the situations where you may have to consider elective tracheostomy. But again, we do not do this tracheostomy before we induce this patient, because what if this patient is inoperable? Second, what if the resection is not as much? So this decision is usually taken at the end of surgery. One of the post-operative airway complications is vocal cord palsy. Traditional way of looking at it is extubating the patient deep and doing a laryngoscopy and checking it. But with the ultrasound now available for us, we actually would wear sterile gloves, cover the ultrasound probe, and look at the cords. As you can see in this video, that you can identify that one cord is moving relatively less as compared to others. So this can help you anticipate problems and plan the extubation. This is the last bit of my talk. Hematomas. There can be hematomas in a case that, say, you have operated in the morning and you're called in the middle of the night for hematoma exploration. Remember, not all hematoma patients would require anesthesia. As long as they're lying comfortably, you give them oxygen. Most of the skin around there is denervated, and just opening the flap does not require you to sedate the patient unless there is some other reason to do so. So that's one way to get away with it. This is one of the patients that we had recently who was in so much stridor. You can look at the distress. He just refuses to lie down. And in such patients, they need to do a tracheostomy, and you might get away with giving a very low dose of ketamine and dexmedetomidine, but be extremely careful. Give it in literally minute like we gave 10 milligram of ketamine along with 0.25 mics per kg of dexmedetomidine, and I had to repeat that once again. And that's about it for this gentleman. Carotid blowouts, where actually tumor invades one of the big vessels and there is bleeding, is yet another an emergency. And for any bleeding patient who comes, securing the airway is utmost important. The traditional way of doing it would be getting a quick tracheostomy done. But if there is a lot of bleeding, then this is one way that I like to do. You can see that the patient is sitting up, because if the patient lies down, all the bleeding is going to keep collecting in the mouth, and there's so much of bleeding, he's just spitting out the blood, as you can see in the tray. I like to do a fiber optic from the front so that the blood does not come in the way and I can still secure the airway while the patient is relatively awake. This was a very interesting case. We extubated the patient, and you can see that there is a lot of bulging there on the airway. So this was because there was a tracheal rent, and as long as the tube was there, it wasn't identified. And the moment we extubated, this thing started bulging. Yeah, we have 10 minutes left. So just to summarize, I think there are innumerable challenges. I'm sure so many of you have faced so many challenging scenarios. And in case you want to share it with me, I would really be happy because it would add to my knowledge. Airway assessment is crucial. You have to flag the obstructive lesions and treat them in an individualized airway plan. Intraoperative vigilance is crucial, and extubation needs to have plan. Nevertheless, there can be surprises. Thank you so much for patient listening. And sorry for stepping over the time a little bit.